screening tool, but mostly we do CT scan, and MRI is done for like as a problem solving tool, or if we want to delineate ductal complication or to show cystic component. So mostly for pancreas we are doing CT because it shows calcification well and vessels and all that can be nicely seen. So CT is mostly used. Now a few words about CT protocol. Generally in other in NGOs we do arterial and venous phase imaging, but in pancreatic imaging there is a phase called pancreatic phase, which is about 35 to 40 seconds. And this phase is good for detecting the adenocarcinoma which are hypovascular, and I'll be showing you an example. But if you are interested only in seeing arteries, or if you are suspecting a neuroendocrine tumor, then we prefer early arterial phase. But if we are strongly suspecting adenocarcinoma, then pancreatic phase is taken, and portal venous phase is taken in most of the patient, and this is good for delineation of the venous structures, any hepatic metastasis. So one additional phase is the pancreatic phase. So like in this example, there are same patient, three images. First is arterial, second is pancreatic, third is the portal venous phase. So in the pancreatic phase, the pancreatic parenchyma is nicely enhancing, while the hypovascular adenocarcinoma is not well enhancing. So this adenocarcinomas are best seen on the pancreatic phase. Now coming to the solid tumors, so depending on whether the tumor is solid or predominantly cystic, we base our differential diagnosis. So the most common is adenocarcinoma, and then we also rarely have neuroendocrine tumors and solid pseudopapillary tumors and metastasis, and rarely there are some mimics which can mimic like focal pancreatitis or IgG4 disease. They can mimic a mass lesion, but they are not malignant. So coming to the first one, this is the most common and mostly seen in elderly people, more common in male. But usually it is hypovascular, as I showed you on pancreatic case, and they cause a lot of fibrosis, causing narrowing of the MPD. If they are in the head region, they will cause narrowing of the CVD, MPD dilatation, and if there is a vessel nearby, they can invade the vessels. And generally, CT is done to see the resectability, and first we see any distant metastasis. If there is no distant metastasis, then we have to assess the local tumor disease in detail and to see all the vessels like superior mesenteric artery, celiac axis, GDA, SMPS. So all these structures and the lymph nodes, they have to be seen to decide the staging and resectability. Now, as you know, that pancreas is intimately related with the superior mesenteric vessels. Also, celiac axis, common hepatic artery, splenic artery, gastroduodenal artery. These vessels are in close vicinity to the pancreas, and they are sometimes involved. Now, coming to the terminology, generally we use the terminology that is abutment. If the tumor is touching a vessel with angle of contact less than 180 degree, means 2/4 of a vessel is in touch with the tumor, we label it as abutment. While if the tumor is surrounding the vessel by more than 180 degree, we call it is encasement. So abutment is generally say about 40% there are chances of invasion, whereas in encasement there are more than 80% chances of encasement. And sometimes there may be irregularity of the vessel wall that is suggestive of invasion. So these are the things we are going to see. So I'll be showing cases mostly. So this case, so we can see there is a mass lesion in the is there a cursor, pointer? Okay. Yeah. So anyway, so there is a mass in the head of the pancreas, and you can see the superior mesenteric artery. And also, so So this is the mass, and this is the superior mesenteric artery, and this is the superior mesenteric vein. We can see there is a little bit fat plane with the superior mesenteric vein, but with the superior mesenteric artery, there is loss of fat plane, and about more than 90-degree contact of the mass with the superior mesenteric artery, and slightly lower down. This is the superior mesenteric artery, and the tumor is nicely abutting it. So we will mention that the tumor is abutting. There is loss of fat plane. This is an example of vessel abutment. In the second case, this is the mass, and here you can see this is the SMA, and all around the SMA the fat is gone, and the tumor tissue or the soft tissue is surrounding the vessel. So this is encasement, and there are higher chances of infiltration. In this case of pancreatic CA, we can see there is a mass rising in the neck region of the pancreas with impeded dilatation, and this tumor is infiltrating the celiac axis branches, causing narrowing and also hurting the SMA. And lower down, it is also encasing the aorta, you can see. So it's a very advanced disease. Okay. So another case, here we have a mass in the head of the pancreas, and we can see it is almost 180-degree in contact with superior mesenteric vein, and this is the artery. So about 90-degree contact with the artery, about 180-degree contact with the vein, and slightly lower down, if you can see, it is also causing narrowing of the vein. So here we have both. We have involvement, and on the coronal reconstruction, we can see that the tumor is causing scalloping of the wall of the vein, superior mesenteric vein, and there are also necrotic nodes. You can see these are the nodes, although some of them are small, but their morphology is not normal. They are showing heterogeneous enhancement. The central area is hypoenhancing. So pancreatic carcinomas are known to give rise metastasis in small size lymph nodes. So we have to be very cautious with the lymph nodes. Again, just a few words about lymph nodes. So any lymph nodes which is around aorta or left to the superior mesenteric artery is generally considered as distant metastasis. Like in this case, this node is on the left side of the superior mesenteric artery. So I think you people must be knowing better how to deal with these nodes, um, uh, but these are the nodes which in literature have been described to be as distant metastasis, while other nodes like periportal nodes and peripancreatic nodes, they are taken care of. So not only the local disease, sometimes the local disease may look resectable, but you have to be very careful, and you might find the metastasis in the liver. So sometimes even if the local disease may be resectable, but if there are lesions in the liver, then it could be metastatic disease. Sometimes we have perineural spread, and here what happens, the actual tumor is not going directly into the vessel, but what we see that all the fat around the superior mesenteric artery has been replaced by a soft tissue rim. Although tumor is at a slight distance, but we can see there is a cup of soft tissue around the vessels. And if you see something like that, we should suspect there is a perineural spread via this celiac plexus. So this is very important to be seen. Now, coming to the confusion of the mass versus focal pancreatitis, it's not always easy to tell whether it is a mass or focal pancreatitis. Sometimes history helps. In literature, people have described that in chronic pancreatitis there is delayed washout, whereas in pancreatic carcinoma there is increasing contrast without washout. But more definite is that if you can see like irregularity of the arteries around that, you can be more sure that this is like malignancy. And if there is the confusion remains, then sometimes we have to do FNAC or biopsy to confirm whether it's a adenocarcinoma or focal pancreatitis. Chronic pancreatitis patient also they are more predisposed to develop these malignancies, and they are very confusing whether the lesion is actually part of the focal pancreatitis or a malignancy is developing. So in this chronic pancreatitis patients, usually they develop acute exacerbations. So in these patients, we have to be cautious and we have to look carefully for the development of metastasis, like in malignancy, development of malignancy. So in this case, there is a mass which is developing in the head region. So this is also a complication of chronic pancreatitis. Now coming to the neuroendocrine tumors, generally neuroendocrine tumors, their presentation depends on whether they are hormone secreting or they are not. So like in cases of insulinoma, they present at a early stage is where the tumor is small. Because of the hormone, they are causing symptoms and patients undergo imaging and they are detected as a small when they are small in size. And generally, neuroendocrine tumors are quite hypervascular. As you can see, this is a MIP image nicely showing the hypervascularity in the lesion with which is showing washout also. So neuroendocrine tumors, small ones can be hypervascular, while the large ones may be heterogeneous, and especially if they are non-secreting tumors, then they tend to grow and present late, and then sometimes we have to do biopsy to prove the nature of the lesion. Now coming to the solid pseudopapillary tumor, this is a rare tumor, but we have seen few cases, especially in young girls. So in young girls, when they come with a large pancreatic mass, we suspect this entity that is called solid pseudopapillary tumor, and they usually at presentation they are usually large and they are slow growing, and sometimes they undergo cystic change. So there may be areas of the cystic, but usually we see a solid component also. So this tumor, although rare, but in young, especially in young girls, we have seen few cases of solid pseudopapillary tumor, and at presentation, usually they are quite large. So now coming to the cystic tumors. So cystic tumors, we have again 3-4 common cystic tumors. So the first one is intraductal papillary mucinous neoplasm, then serous cystic neoplasm, mucinous cystic neoplasm. And those tumors which present as solid, they can also present as cystic due to cystic degeneration, like solid pseudopapillary tumor or even neuroendocrine tumors or adenocarcinomas. Sometimes they look cystic because of the cystic degeneration. But the most important thing is that pseudocyst, we must differentiate whether the cystic lesion is a pseudocyst or a neoplasm. So that is the first thing we should try to differentiate. Usually the history is very important in making the diagnosis of the pseudocyst. If there is no history, then suspicion for a neoplasm is more likely. And sometimes pseudocysts can have some debris, but usually that does not enhance. And they so if there is a cystic lesion in the pancreas, then there is no history of pancreatitis, there is no history of trauma, and the lesion shows presence of internal septations, solid component, calcification, or a scar, then we suspect cystic neoplasm rather than pseudocyst. So this entity is serous cystic neoplasm, usually seen in elderly females, and generally they have a bunch of clusters of cysts, multiple cysts with thin septae, and we can have central scar with calcification. So this is the typical pattern. Like in this case, we can see there is a mass lesion which is cystic with multiple thin septa, and in the center there is a scar. This patient also had renal cysts, and it was a part of a syndrome, VHL syndrome. Another patient, this lady again presented with cystic lesion with a central coarse calcification, and after contrast we can see some thin septa and a central calcification. So if we are seeing a cystic lesion with a central calcified scar in an elderly lady, usually diagnosis is serous cystadenoma. Now coming to the mucinous cystic neoplasm, these ones are having a more malignant potential compared to the serous ones, and they are also common in female, but the age is somewhat less. So they are in age of 40 to 60 in females. Sometimes there can be only one cyst, or there can be multiple cysts, but usually the size of the cysts are larger in the mucinous cystic neoplasms compared with the serous cystadenomas. And also the septations are thick. Sometimes they may have peripheral calcification, and as mentioned, they have more chances of malignant malignant transformation or malignancy. This is a case where the lesion looks quite simple cystic, but if we pay attention to that, in the walls we can see some thick enhancing septa. In one of the wall we can see calcification, and also there was no history of pancreatitis. So if we are seeing this kind of picture and we can see some thick septa, some mural nodule in the wall, or some calcification, then we should suspect mucinous neoplasm. Another case where we have quite thick septae and which are enhancing also. So this is like this is a case of mucinous cystic neoplasm. Now coming to the intraductal papillary mucinous neoplasm, these tumors they can be of main duct type or the side branch type. In the main duct type, usually finding the tumor is very difficult on imaging. Usually, what we see is the dilated MPD, and sometimes ampulla may be prominent on imaging, but on endoscope, people can see mucin pouring out of the papilla, and that's how the diagnosis of main duct IPMN is made. But in side branch IPMS, you can have a clustered or bunch of grape kind of cystic appearance. Like in this case, we have a clustered cystic appearance in the tail of the pancreas, and on MRCT images, we can see the communication with the MPD, and also you can see the MPD is more dilated in the tail region. So this is due to the secretory nature of these tumors. They tend to produce a lot of mucin, and they cause dilatation of the ducts. So this is how they look. Again, they are more common in elderly people. So this is one case which we are following. This is a case of uh, side branch IPMN. Uh, Thank you very much. So this is. Anybody has any questions? Or you are thoroughly saturated? Oh, sorry, what about the autoimmune pancreatitis? So autoimmune pancreatitis versus malignancy, how to differentiate? As I mentioned, sir, generally in this imaging wise, if we see invasion of the vessels, narrowing of the visceral arteries, then we suspect more of this malignancy. And also age also is late. But if we have confusion, then biopsy. We can do biopsy many times. We are not sure on imaging which biopsy. Many sessions were very interesting, and they were learning a lot of learnings. But what is most important, I think, is the radiologist, and we have to look radiology from the clinical point of view, and we should always look at all this from how this is going to be clinically useful to you, and the discrimination between what we are willing to do. I think that's the learning point of this. So I think that's of course interaction, but we should put to a clinical viewpoint of what is useful to me, what is going to help me in making decision, diagnosis, treatment, follow-up. I think that is what we should really always ask to these radiologists.
In a sense, what you're saying is talk to the radiologist.
Yes.
Can't just sit on a report or a film.
No, see, one of the big problem is many people I've seen just go and picking up a report. Many times don't see the films also. Yes. But there are so many
Visualization, same visualization, you have to
yes.
multiple present. Thank you so much. I think Lavina,
This actually end our day today. and we all will move to the gala for the gala dinner at the hobby center near the guest house in the SGPGI complex only. And we will meet tomorrow at 8 a.m. sharp for and before starting the session, there will be breakfast provided from 7.
Thank you, everyone.
नहीं इधर ही देखो डिस्कनेक्ट हो ताकि प्रदीप ने मार्क दिया है तो restriction right there. Right.